My dear students, Dr. Ashfaq over here, and as you are well aware, I have authored books for NEET PG, NEET DM, NEET MCH, as well as some of the books for vvery examinations, MRCP examinations, and my lectures would be intended to get you right on the top there for your next examinations, DM examinations, MCH examinations, MRCS, MRCP, vvery examinations. I hope my videos will benefit you a lot. I will be presenting my things in a very easy, simple and palatable form for you. Wish you good luck for your exams. Thanks a lot. My dear students, today we'll be dealing with a very important region of the abdominal pelvic cavity, and that is the inguinal canal. And along with the inguinal canal, we will be dealing with the surgical anatomy, the surgical aspects, and inguinal hernia in detail. There are many questions which I have found being asked from this part in the recent years, so it needs a bit of an emphasis in a more detailed fashion. So as far as the inguinal canal is concerned, you students are well aware of the fact that you can have a look at the board. So as far as the inguinal canal is concerned, you have to remember that we have got a very important structure in the inguinal region, and that is the inguinal ligament. Along the medial part of the inguinal ligament, we have got this very important canal which is given the name as inguinal canal, and basically it is an area between two rings, and one ring is the deep inguinal ring and the other ring is the superficial inguinal ring. As you can have a look at the board, and over here this is the area of the deep inguinal ring, and this deep inguinal ring is basically a deficiency in the fascia transversalis. So over here we have got a mid-inguinal point, and just 1.2 centimeters above the mid-inguinal point we have got a deep inguinal ring which is oval shaped. So we have got this oval shaped deep inguinal ring which is basically a deficiency in the fascia transversalis. And over here we have got a superficial inguinal ring which is a triangular ring, and it is basically a deficiency in the aponeurosis of the external oblique muscle. So two rings, one is the superficial inguinal ring and another is the deep inguinal ring, and over here we have this canal, and this canal is the name inguinal canal, which is almost 4 centimeters in length, and the direction is just downwards, forwards and medially. So you can see the deep inguinal ring is situated a bit higher and the superficial inguinal ring is situated a bit lower. Now as far as the superficial inguinal ring is concerned, we have got it as a triangular deficiency. So this is triangle shaped and the deep is oval shaped, a very important structural difference. And over here this triangle has got obtuse angles in it, and this is obtuse angle triangle. So sort of this with small fibers in between them, which we give the name as crural fibers, which help in maintaining the integrity of the superficial inguinal ring. Now as far as the superficial inguinal ring and the deep inguinal ring and the part inguinal canal is concerned, we have to remember what are the boundaries of the inguinal canal. So as far as the inguinal canal is concerned, you can have a look at the figure. As you know the anatomy of the region. Over here we have got an important muscle which is the external oblique muscle and the internal oblique muscle. The skin, the fascia and the external oblique muscle form the anterior wall of the ring, and in the lateral part the internal oblique muscle forms an important anterior relation as well. So skin, fascia, superficial fascia, the external oblique muscle and the internal oblique muscle form the anterior relations of the ring. Now as far as the posterior of the canal, as far as the posterior relations are concerned, we have got the transversalis fascia, and behind the transversalis fascia we have got the extraperitoneal connective tissue, and behind the extraperitoneal connective tissue we have got the peritoneum. So you can see the transversalis fascia, the extraperitoneal connective tissue and the peritoneum, they form the posterior relations of the inguinal canal. Now as far as the roof of the inguinal canal is concerned, the internal oblique muscle again comes into action and it forms the roof of the inguinal canal. As far as we have roof, once we have a roof we have a floor, and the floor of the inguinal canal is formed by a ligament which we give the name as inguinal ligament. So these important boundaries and relations are very important as far as the inguinal canal is concerned. Now, in action, you have to remember one important thing. There is the conjoint tendon, and conjoint tendon is a very important tendon which is formed by the two muscles, and they are the internal oblique and the transversus abdominis. So conjoint tendon is a combination, is a tendon formed by the tendinous fibers of two muscles, and one is the internal oblique and another is the transversus abdominis. So this is something about the relations of the inguinal canal as a whole. Now, why is this inguinal canal important? Because through the inguinal canal passes a very important structure, as in case of males as well as females. In case of males, there is the spermatic cord which passes through the inguinal canal, and in case of females there is the round ligament of uterus which passes through the inguinal canal. Now, why is this spermatic cord important? The spermatic cord, the inguinal canal, is important because in the spermatic cord lie many structures, and this structure should be preserved in most of the cases, and a surgeon has to be very careful while dissecting in this region, in the inguinal region, because of the presence of spermatic cord and the associated structures, because along with the spermatic cord, the ilioinguinal nerve also traverses through the inguinal canal. So as you can have a look, this is a section which shows the spermatic cord and what are the contents of the spermatic cord. A question quite frequently asked. As you can see, this is a cross section of the spermatic cord. Over here you have got the ductus deferens or the vas deferens, a very important structure, the passage or a pathway for the conduct of sperms, and this ductus deferens lies within the spermatic cord. And as well, you have got the genital branch of the genitofemoral nerve. That's very important. The genital branch of the genitofemoral nerve is a very important structure. It lies within the spermatic cord. And in addition to that, we have got the testicular artery. We have got the testicular artery as well as the cremastic artery. These two important vessels lie within the spermatic cord. In addition, a venous plexus, which we give the name as paterniform plexus of veins, very important plexus of veins, which we have already discussed, is very important from this perspective because it lies within the spermatic cord. And this spermatic cord is covered by the external spermatic fascia, the internal spermatic fascia, as well as the cremastic fascia. So these are some of the important structures in addition to the sympathetic nerves and the lymphatics which lie within the spermatic cord. So the contents of the spermatic cord you have to remember, and this spermatic cord traverses within the inguinal canal in case of males, along with the ilioinguinal nerve which lies outside. The genital branch of genitofemoral nerve lies inside the spermatic cord, and ilioinguinal nerve lies outside as a content of the inguinal canal. Very important. So you can see all these structures. If you cut the spermatic cord, you are just dissecting all these structures. Very carefully to be taken note of. So this is something about the spermatic cord and the contents of the spermatic cord. Now, why do we study this region? Because of the fact that these rings pose a risk because they are sites of weaknesses within the abdominal pelvic region. And what can happen, there can be herniation of the abdominal contents through this region. So we can have the abdominal contents coming out through the superficial inguinal ring, traversing through the deep inguinal ring, and that can cause inguinal hernias. Now, this inguinal canal is larger in case of males. As a result, the inguinal hernias are more common in males. So that's one important anatomic difference, and the larger caliber of these rings which predispose a male to the more development of inguinal hernias as compared to females. So that is one important thing. Now you have to take note about, there are two types of hernias basically which can occur. One is the direct type of inguinal hernia and another is the indirect type of inguinal hernia. And what do we mean by a direct type of inguinal hernia? The direct type of inguinal hernia traverses through the posterior abdominal musculature, and that is direct. It directly comes through the posterior abdominal musculature, and the indirect inguinal hernia just traverses the path of descent of the testes to the deep inguinal ring and to the superficial inguinal ring. And what is important as far as the indirect inguinal hernias is concerned, there's an important triangle which is formed over here and which we give the name as Hasselbeck's triangle. As you can have a look in the figure, this is the Hasselbeck's triangle, and this, the boundaries of the Hasselbeck's triangle are the lateral boundary of the rectus abdominis, and this is the inguinal ligament over here, and this is the inferior epigastric vessels which form the upper boundary of the Hasselbeck's triangle. And most of the indirect hernias happen to be in the region of the Hasselbeck's triangle, and most of the direct hernias happen to be a more bit lateral. So this is a very important difference between the inguinal hernias, direct and indirect type. Now, as far as the inguinal hernias are concerned, you have to know that abdominal contents can come and through this inguinal canal. At a stage, initially, they can present with them small swelling within the inguinal region, and depending upon how much of a herniation there is, they can be present within the deep inguinal ring, they can be present in the inguinal canal, they can be present in the superficial inguinal ring, or even they can descend into the scrotal sac. But there's an important thing you have to remember, that in the initial stages that they cannot be that much dangerous, but as far as the progression of the hernia is concerned, they come to a stage wherein they are irreducible. That means they cannot be taken back into their cavity back. So we can reduce the hernias, we can insert a finger and then track the hernias through the superficial inguinal and drag them back through the deep inguinal ring up to their abdominal cavity proper. But what happens in certain cases, the inguinal hernias, they just get irreducible. That means they get enlarged. There's a lot of obstructive symptoms which occur later on, and they can get strangulated even, and they can cause gangrene and subsequent secondary changes, rupture, perforation of the viscera, and that can be catastrophic because they can just cause peritonitis as well higher up. So one thing is that the ability of a student of a medical to just recognize a small region, a small lesion or a small swelling in the inguinal region as inguinal hernia is to be just taken care of. A student, a medical student or a doctor in the OPD has to realize inguinal hernia at the initial stage, at a stage at which it can be reducible without much complications. That hernia can be reduced back, but in case it progresses more, it just tends to get exaggerated as far as the symptomatology is concerned. So that is very important, that you have to just know how to diagnose a small swelling in the inguinal region as an inguinal hernia in the initial stages, at a stage at which it is reducible. Now, who are the people who are just prone to get hernias? You have to remember that for proper development of hernias, there is something important, and what is important is that you should not have a poor tone of the muscles. You should not have a poor musculature. The muscle tone should be well maintained. So these hernias are more common in case of elderly patients who are having a poor muscle tone. They are more common in case of debilitated patients. They are more prone in case of malnourished patients because they don't have the muscle tone to just prevent the herniation. Number two is that there are a certain group of people, chronic constipation as well as chronic coughing as a result of many diseases. These patients put an unnecessary load on these rings, as a result of which there is more herniation, of chances of herniation. So inguinal hernias are more in case of males because of the larger size of the rings. Number two, in case of debilitated patients, in case of malnourished patients, in patients with chronic diseases which cause malnutrition, in case of patients with chronic constipation, in case of patients with chronic cough like previously tuberculosis of the chest, and these patients predisposed to herniation more. Now, what are the mechanisms in the body which just help in prevention of the hernias? We can go back to the anatomy of the rings. Now, as far as these rings are concerned, you know that these rings are not vertical or horizontal, they're obliquely placed. So one important fact is that the obliquity of the canal in itself is a preventive mechanism which does not cause herniation. Had these rings been aligned in another direction, had they been at the same plane, there would have been more chance of herniation. So the obliquity of the canal in the first instance is a very important factor which just prevents the herniation. Then second thing is the relation of the internal oblique muscle, anterior relation, posterior relation, the roof. Once this internal oblique muscle contracts, what it causes? It causes contraction of the rings. And what happens, the three relations which it causes, the canal as a whole is closed, and the triple relation of the internal oblique muscle to the formation of the inguinal canal itself helps in prevention of the inguinal hernias. Number third, there is this contraction of the external oblique muscle at the superficial inguinal ring, which causes the superficial inguinal ring to close, and as a result of which herniation through the superficial inguinal ring is prevented. In addition to this, there is this muscle tone which is regulated by the nerves, and in addition to the hormones which regulate the muscle tone, they help in maintaining the integrity of the rings. And there is this conjoint tendon and the cremasteric muscle also, the contraction of which helps in prevention of hernias, because they close the inguinal canal either at the level of superficial inguinal ring or at the deep inguinal ring. So the contraction of the muscle as a whole, whether it is cremaster, whether it's internal oblique, whether it's external oblique, or the conjoint tendon, they help in closure of the canal, especially the rings at their specified locations. So this is something about the inguinal canal and inguinal hernia. This topic is quite a favorite of the examiners. This topic is quite asked in the examinations like the NEET PG. Hopefully the next it will be asked as well. Hopefully it is asked in MRCS as a part of surgery evaluation, as well as USMLE surgery. I hope that you will be taking up this region with a lot of concentration, and this small class of mine might be helpful to you. Thanks a lot.